As far as pulmonary risk, things that can increase the patient's likelihood of having perioperative risk, or if they have advanced age, heart failure, COPD, if they're smoking, any kind of airway disease. And then if any patients who you suspect are at higher risk, then obtaining PFTs, chest x-rays, and an ABG will help give you that information. This is images of chest x-rays. On the left-hand side, it's a patient with COPD, and on the right, it's a normal chest x-ray. And also, when you get this, how you're going to use that information to decrease the risk of perioperative complications. Obstructive sleep apnea. These can cause a lot of systemic issues in the patients. If you think about it, it's periods where the patient can have significant hypoxia, and it's depending on the patient or the patient's body to wake them up, whatever that might be, hypercarbia or hypoxia. So patients are living with these variable oxygenation statuses. So when they do go to sleep, you're looking at the tongue going back and kind of closing the area between the tongue and the upper oral or the upper pharynx, the hypopharynx. So this can cause periods where there's blockage of consistent air movement, and these can give you perioperative risks. The patients are more likely to have diabetes, hypertension, arrhythmias, and organ disease, and the patients are more likely to have issues with ventilation and intubation. Oftentimes, patients are undiagnosed and untreated. So if you have a suspicion, treat them as if they do have sleep apnea. There's certain therapies that include sleep apnea. They might have surgeries that can take away structures that can lead to these obstructions. And then any lifestyle changes, stop smoking or lose weight can help with the soft tissue and the airway irritability. There is a scale that's out there that's called the Stop Bang questionnaire. Sometimes the nursing team will administer this to the patient and give you the score. And what this score tells you is the likelihood that the patient has sleep apnea. And the higher it is, the more likely they will have sleep apnea, and the more likely the sleep apnea will be severe. For most surgeries, you do not need to stop or delay surgery to get this confirmed with a sleep study and get them on CPAP, knowing that the patient is more likely to encounter periods of sleep apnea, and that can be up to 72 hours after anesthesia administration has stopped. Then you would find ways to monitor this patient or change the amount of, let's say, opioids you administer. For patients who have renal disease and who are on dialysis, it's having baseline renal insufficiency is the highest predictor of perioperative worsening of renal function, because anything can cause, if in a kidney that's already diseased, any changes to their blood pressure, their heart rate, their perfusion to the kidneys can cause acute renal disease, and that's more likely in a patient that already has chronic renal disease. If a patient is on dialysis, I would say get the dialysis the day prior to surgery, and then have it again the day after surgery. A dialysis comes with a lot of shifts in electrolytes and fluids, and the day that patients are more likely to have a hemostatic state of their blood volume, their volume in general, as well as their electrolytes, is going to be that day in between. And the recommendation out there is if the patient has a potassium of less than 6, no EKG changes that are associated with peak T waves, and the patient is potassium within their established range, to proceed, and then to avoid some nephrotoxic medications and any significant changes in blood pressure. Let's see. And let's see, question for you guys. If it was this is an emergent surgery in a patient who is getting dialysis, has been non-compliant with dialysis, and you see a potassium of 6, but the patient needs emergent surgery and just had a full meal before coming in. Would you give them succinylcholine for rapid sequence intubation, knowing what their potassium is, knowing that you need this rapid sequence induction, or would you have any reservations with a potassium of 6? So the answer is no, and that rocuronium would be used to provide the patient with muscle paralysis. And I am on board with you because succinylcholine can increase the potassium by 0.1 to 1 milliequivalents per deciliter, and that can cause arrhythmias. There's various things that can occur in the perioperative period that can lead to acute renal issues. And so acute renal issues that don't resolve, whether it's with time or with intervention, can then come on to, the patient can go on to have chronic kidney disease, and that can become a significant cycle to their medical stability. Diabetes. There's many, you're going to see many different guidelines, many different discussions about diabetes. There's many ways that patients maintain their diabetic care, whether it's diet, oral, subcutaneous, a insulin pump, many ways that the patient can maintain their diabetes. And even with that, sometimes that can cause significant instabilities. So for surgeries, especially emergent, urgent, or time sensitive, trying to get the patient within a range that's not extreme. And extreme ranges can vary depending on what the patient's body is used to. So if their patients are living in the 200s, and extremes for them where they might get symptomatic are in the higher 300s, or hypoglycemia might be 100, whereas a patient who lives in the 400s might not detect anything in a range that another person might. So be aware of what the patient's range is, reported or actual. This is where hemoglobin A1C comes in. Very valuable information, giving more information rather than what the patient's glucose is on the day of surgery. Remember that sometimes a patient is on steroids, which can iatrogenically increase their glucose levels, and the patient might be stressed, so that can increase their sugar levels. So many things that can increase it. So knowing what to look for, asking the patients about their range, making sure that there's no symptoms and they're not developing any symptoms. And even beforehand, having them see an endocrinologist or a diabetes specialist so they can alter their perioperative regimen to help optimize them. This is going to be really valuable. So this is something that should be done well before day of surgery. I would say within weeks before surgery. Obesity is based on BMI. So a BMI of greater than 40 is usually called morbid or extreme obesity. And with obesity of any range, that can come with also end organ issues, diabetes, cardiovascular issues, liver disease, kidney, gallstones, can affect their pulmonary issues, can cause the pain throughout the body, and have a management with airway and sleep apnea issues. And so to be aware that obesity is very systemic in terms of how you think about the patient's medical comorbidities. Anemia. The patients who have chronic anemia are patients who are more likely to be able to move forward. They've adapted to this. However, finding out more about a patient whose hemoglobin is very low, usually in the range of 6 or 7, or who might have acute changes in their hemoglobin range, is going to be very important to help you determine whether this patient is stable for surgery. Again, the amount of time, the resources, the ability to postpone this time urgent surgery, that all is involved in the collaborative discussion. Some patients might require preoperative transfusion of blood products, especially if the patient's symptomatic and you think there's a likelihood that this surgery will have high blood loss associated with the surgery. Type and cross and have products readily available, whether this is having a way to go to a cooler that's nearby or to have a cooler in the room, so that you can be in the room and don't have to retrieve it from different locations, therefore spending some additional time getting those resources. Consult hematology for high-risk patients. These can include patients who have sickle cell anemia, various bleeding disorders that special factors might need to be ordered, or the patient might have antibodies that might be more rare. So blood products might have to be prepared well in advance. And determining the cause of the anemia, especially acute changes to anemia, are very important because during surgery, there can be also additional blood loss. So if we're able to stop the ongoing cause of blood loss that's not related to this surgery, that will help optimize the patient. There's various symptoms can come with anemia. Sometimes if it's something that's been progressing over time, the patients might not have the acute change, and you might not see all these symptoms, but these are some things to look out for. Preoperative medications, oftentimes we would continue most medications. Some of the blood pressure medications, we tell patients to hold off the evening before. However, most times we will tell the patients, take your medications as you would on the day of surgery. We do advise patients to stop smoking. Even a few hours or a day can improve their pulmonary status and decrease complications. Post-op nausea and vomiting. This is something that is very uncomfortable. It can cause increased intraocular pressure, increased intracranial pressure, abdominal pressure, in addition to being uncomfortable. So in someone who's had fresh surgery, this is not a state that you'd like to be in. So if a patient has a high number of risk factors, female, history of post-op nausea, vomiting, or motion sickness, a non-smoker, retrieving post-operative opioids, the more risk factors, the more antiemetics you would want to give the patients to help prevent this. So these, when you think about these risk factors, I would say even if the patient has no risk factors, I would give them at least one antiemetic. This is something that we're kind of moving above and beyond NPO past midnight. The reason before is if patients had anything that had not been digested through their digestive system, that there would be a chance that there would be gastric emptying that would lead to having contents in the oral pharynx and then causing pulmonary aspiration, which comes with a significant medical comorbidities and mortality. So for the recommendation for patients who are healthy, undergoing elective surgery, getting regional or general anesthesia is that waiting at least 8 hours after having a heavy meal. I would say with a lot of the meals that we can pick up and go, that's considered a heavy meal. A lighter meal can usually wait, can have that 6 hours before. For pediatric patients who are still on breast milk, 4 hours. Having clear liquids, we encourage, instead of saying NPO after midnight, kind of encourage the intake of all this up until a certain amount of time. So hopefully the patients will have intake of fluids. Some will have electrolyte drinks such as Gatorade up to 2 hours prior to when we give them anesthesia. This will replete them, have them in a state of less fluctuations in their volume and their electrolytes, and kind of have them more primed for surgery. So if you have all the things in mind, this is an example of maybe if you were starting out as a first year resident, as an intern doing your anesthesia electives, as medical students on your anesthesia or advanced anesthesia clerkships, I would say have a tool that you can use that makes sure that you think about the whole picture and what some of your plans are. Because it's great if you progress during your clerkship that you have a plan. You present the patient with the pertinent positives and negatives, and have a plan and recommendation on the perioperative course that includes recovery. So that would be something that would add a high educational value to you and to your team. So the types of anesthesia, and I'll go through this a little quickly for sake of time. So the types of anesthesia, we have many. They range from local, where we provide blocks to that area, doing a nerve block or peripheral local block. Regional, where oftentimes I think of that as epidurals and spinals on OB, or orthopedic or abdominal procedures. Having sedation, where the patient can be fully aware of what's going on and might or might not have some cooperation associated with it. Where to full general anesthesia, where you likely will need to assist their ventilation, their oxygenation, and their cardiovascular status. So there's many things to consider for when you consider the type of anesthesia that you will be administering to the patients. And this is based on various things, including the patient's safety as well as the patient's input. I hesitate to say the patient's preference because the preference could be something that they might want, or they might have heard a friend, or they might have heard about, but that might be not within the medical knowledge that you might have, or that what your considerations might be. So I always consider a team to talk with the patient, in front of the patient, and gauge where they're coming from, because it can be something that we might not be considering as part of their medical team. So that with ideal anesthesia, you want to have optimal patient safety and satisfaction, optimal surgical conditions to have allow the surgery to proceed safely and timely, allow for rapid recovery, whether it's discharge home or discharge to a hospital bed, and avoiding post-operative complications, nausea, pain, and cardiovascular and pulmonary changes. Have it be economical and efficient for both the patients and the hospital system, so that we can get more patients in safely without delay. And have a collaboration with all your clinical care teams. I should put nursing team here as well, because they are often very strong patient advocates. So with all your clinical teams. The stages of sedation, if you do decide to provide more on the sedation scheme of things, is that you can have minimal sedation, where you're providing the patient with relaxation. I think of having a glass of wine or taking a Xanax, where the patient is able to respond to verbally to you, open their eyes, to have engagement and eye contact with you. And then patients who have moderate sedation or analgesia, they respond to verbal or tactile stimulation. So a light tap on their shoulder might reorient them into the room. Deep sedation is where a purposeful response is usually followed by maybe repeated calling their name, shaking their shoulder, or even a painful stimulation. So the type of sedation that you administer to the patient should be in line with the goals of the surgery, of the patients, and making sure they're safe and comfortable. General anesthesia can be administered in various ways. Then usually the two types are intravenous and inhalational. You might see patients getting intramuscular anesthesia, and oftentimes that's for patients who are not able to participate or be a part of intravenous or inhalational anesthesia. Before giving anesthesia, we might administer a sedative orally, IM, or otherwise to help with this process. And ASA monitors are placed, blood pressure, EKG, and pulse ox monitors. Pre-oxygenate the patient. This is an active period where the patient is helping to take deep breaths with 100% FiO2 oxygen to remove the nitrogen that's within room air, and give you more time to manipulate and engage with the airway should there be any extended apneic periods. Mask ventilation and insertion of the airway device, whatever that might be, and confirmation that the airway device is in the appropriate location, and confirm stability of the vital signs. The ASA monitors, they don't specifically say blood pressure cuff, EKG, pulse ox, but they do tell you that during the anesthetic, the patient's oxygenation, ventilation, circulation should be continually evaluated. And that should be evaluated in the form that is most appropriate for the type of surgery, the type of patient medical comorbidities, and how you can minimize and anticipate any risks. There are situations where we would do rapid sequence induction of anesthesia, and this would involve injection of medication where in a rapid manner, and with these medications that can induce rapid anesthesia, so it has a rapid onset. Oftentimes we'll do this for patients who are not NPO for one reason or another. And then with this, just keep in mind that it can increase your potassium acutely. And sometimes people will give cricoid pressure. This has been in recent literatures. This has been kind of debated whether this helps. The reason that we give this cricoid pressure at the cricoid cartilage is, or actually, do you guys know why are we giving cricoid pressure versus, oh, just anywhere along the larynx? Why are we giving cricoid pressure during a rapid sequence induction? And with the rapid sequence induction, the goal of that is to, avoid aspiration in a patient who has NPO status issues. So cricoid pressure is the cricoid cartilage is the only cartilage that is fully circumferentially around. And yes, completion of the tracheal rings. So it's a complete ring, and it allows for the occlusion of the, nicely worded, occlusion of the esophagus posteriorly. So that, with keeping in mind that if there's any food in there, then hopefully the mechanical pressure will prevent it from going into the oral pharynx. Inhaled induction is when patients might not have an IV for various reasons, a patient who's not cooperative, a pediatric patient. It involves the patient being somewhat engaged with spontaneous ventilation. If you predict that the patient is not going to be that cooperative, I would say turn the nitrous oxide to the highest amount, turn the sevoflurane to the highest amount. Look to when the patient is going to take a breath, and at that point, hold it as close as possible to their nose and the mouth. For example, if a child who's crying, they need to take a breath in between the cries, so you prime or you make sure the highest sevoflurane, the highest nitrous oxide, and then as the patient is crying, and then as they go in for the next breath, you have them inhale. You're prepared for that, and then that is a deep breath, and then that will take maybe another breath, but the patient will likely have a good amount of anesthesia on board. Volatile anesthetics in general will cause hypotension and bradycardia. So if a patient's already starting that way, and if you need high amounts of inhaled volatile agents, be sure to have ephedrine or any other pressors on hand, or maybe giving it preemptively, because almost all of the volatile anesthetics will cause this. Neuromuscular blockades can be given. They have different classes, as well as different duration of action. So if a patient is allergic to a medication, if the case has a certain duration of surgery, then you can titrate in the appropriate neuromuscular blockade. Regional techniques, we can provide that for patients who are getting lower abdomen, lower extremity surgeries, can be combined with sedation or general anesthesia. And you want to confirm the risk and benefits of the procedure, and making sure that although regional anesthetics can provide good analgesia to a certain region, it does come with some associated risks. Oftentimes it can be, it's given in the lumbar region, although we do thoracic epidurals for patients who are getting more the lung or pulmonary procedures to help with lung expansion and pain management post-surgery. And if you've had a chance to do this or see this in OB or other procedures, it's mostly by feel, palpating the spinous processes, going through the ligaments, and going into the potential space, the epidural potential space to put in the catheter. And then if we do a spinal injection, where we go a little bit beyond that to give fluid directly into the spine, or to give medication directly into the spinal space. Peripheral nerve blocks, it's to provide isolated anesthetic effects without manipulation of the airway or prolonged systemic effects. It's a collaborative discussion. One of the information that's valuable is how big the incision will be and where it will be, the nerves that are required to be blocked or nerves that can't be blocked for various reasons, and how long the surgery will take. For some situations, you can do a single shot bolus of local anesthetic, or place a catheter that you can use to provide continuous boluses or continuous infusions of local anesthetics. Sometimes having a separate area to perform blocks can help with efficiency of cases, because if a surgery is being complete and the room is being turned over, it's good to have a patient that's getting their numbing medication or their block. And so by the time they're ready to go into the OR, incision can be made pretty quickly. And knowing the dermatomes of where these nerves lie and what the origins of it, and usually is where the block is placed. Oftentimes, the block is placed under ultrasound guidance and with a patient positioned appropriately with some sedation on board if they're able to have it. Knowing that there's various blocks and various needles that are associated with it. This is the future regional anesthesia, regional pain management. These procedures and these blocks are going to go into the forefront. So knowing about these blocks is really valuable. Some of our take-home pearls, although there are many, our preoperative assessment can really provide you with valuable information about perioperative risks. Start with patient information, direct patient interaction, so that you can get information directly, in addition to supplementing it with chart information. High-risk patients with complex medical comorbidities, acute worsening, or who are likely to encounter perioperative complications might benefit from further or advanced workup. And this involves engaging the surgeons or the preoperative or the PCP or the preoperative providers who know of these conditions and who can bring it to your attention. Collaborative discussion should involve the patients to review the risks and what are the choices for anesthesia and the choices for surgery. Regional nerve block techniques can supplement pain management, and it truly can take some of our cases that are in the hospital to out of the hospital or ambulatory care. So I thank you all for your attention and for engaging in the chat. Yes, I can go back to the regional slides. These are for the dermatomes, and then these are some of the blocks and where you would kind of start or place your needles. Nysora is a NYSORA has a really great website, and it walks you through blocks, how to do it, videos. And it's really great to, if you're thinking about doing it, or if you're going to do it with your team, a great way to review it. So NYSORA, Nysora, will give you a lot of good information about blocks. Okay, any questions that you'd like to ask? I'm going to see if we have any questions in the chat or in the Q&A here. I do not see any. Thank you so much for spending your evening with me. you have, I think I would love for you to contact me if you want to get to know Hopkins, get to know me. Maybe we can collaborate on a few things. My email is, let's see, I'm going to put it on here. Hopefully it is a easy one for you guys to jot down. This was a lot of information, and I'm really so glad that you are able to join. I know your time is valuable. I'm so glad you chose anesthesia because it's a really great field. It's ever growing, both in research and in advances. And you guys are our future. And one day I'll be looking up and you're going to be my anesthesiologist. So thank you. This is really an honor that I was invited to spend this time with you.
Thank you, Dr. Tran.
Thank you so much, Carolyn, for your help.